This video was recorded live with active participation from class attendees. If you have any questions, please don't hesitate to ask in the comments or send a direct message. Thank you and enjoy the video.
Okay. All right. So tonight we're going to talk about two different cold emergencies. The first one going to be frostbite, and we're going to also talk about hypothermia as well. So we're going to talk about how it happens, the signs and symptoms, and also how we treat it. Okay. So your frostbite is a condition in which skin and tissue just below the skin start to freeze. It mostly affects small exposed body parts, such as like your fingers, your toes. People will get it on the tips of their nose as well. With frostbite, the skin gets very cold, then it goes numb, and then it can become hard, and the color will become pale or even blue. Some mild cases can be treated with gradual
Hang on,
warming.
Lisa.
Okay. So frostbite, mild cases can be treated with gradual warming. Some of your severe cases are going to require medical care to prevent complications. Hypothermia. So that is a medical emergency that occurs when your body loses heat faster than it can actually produce heat, causing a dangerously low body temperature. Hypothermia is often thought of as a cold weather or cold water condition, but it can really occur at temperatures well above freezing, even in waters as warm as 80 degrees. So like I said, hypothermia, you can still get hypothermic with temperatures even above 80 degrees. So let's talk about our Great Lakes real quick, right? So Lake Michigan, Lake Superior, we're surrounded by these lakes. I'm sure that many of us have taken a dip or two in these lakes. And so the temperature of Lake Michigan can rise to the high 60s in July. Rarely will it ever make the high 70s. Lake Superior, except for like your shallow bays and beaches along the water, the temperature seldom reaches 55 degrees. So even in the hottest summer weather that we have. So think about, when we're out there swimming in these lakes, our normal body temperature is 98.6, and now we're dipping, putting our bodies into these, potential 55-degree lakes, and we can become hypothermic. So the first picture that you were seeing here with the hand and the black tips of their fingers, that picture there is of someone who had just finished hiking Mount Everest. You can see that she got some frostbite there. All right, let's talk about 5 ways the body can lose heat. So the first way is conduction. That is where the transfer of heat from a part of the body to a colder object by direct contact. So heat can also be gained if the substance being touched is warm. So if you're touching something that's really cold, you're going to transfer that heat, or excuse me, that cold is going to transfer onto you. Same thing if you touch something that's hot. Convection, that is a transfer of heat to circulating air. So when cool air moves across the body, so think of like the wind coming across your body. Okay. Evaporation, conversion of any liquid to a gas. So natural mechanism by which sweating would cool the body is by evaporation. We have radiation. So that is the transfer of heat by radiant energy. So heat loss caused when a person stands in a cold room. Okay. So say they go, when you're working at a restaurant and you go into the freezer to get that meat. Okay. Standing in that cold room. And respiration. So body heat loss as warm air in the lungs is exhaled into the atmosphere, and then we breathe in the cooler air. Okay. That is 5 ways. So some risk factors and vulnerable populations. There's 4 factors that affect how a person can deal with cold. So the first one we'll talk about is the physical condition. So patients who are ill or they're in poor physical condition, they're not going to tolerate extreme temperatures very well. Number two, you have age. So your infants and children and older adults, they're more likely to experience temperature-related illnesses. Infants have poor thermoregulation at birth, and they don't have the ability to shiver and generate heat like we do as adults until they're about 12 to 18 months of age. So it's really important to bundle these babies up. And also it goes the complete opposite way as well. In the summertime, they don't sweat. So we need to really monitor their temperatures in the extreme heat and extreme cold. An infant, they have a larger surface area to mass ratio, so they're going to heat up and they're going to cool down faster than what an adult will. And your children, so they may not think to put on that extra set of clothing when they go outside, right? They just don't have the thought process to do something like that. So they may go outside in shorts and a t-shirt, not realizing how cold it is out there. Your older adults, they have loss of subcutaneous tissue, which is going to reduce the amount of insulation that they have. So, and also poor circulation is going to contribute to their heat loss as well. And also, they're on medications that can affect their body's thermostat, putting that person at an increased risk of temperature-related emergencies. So there's a lot of things going on there with them. They also have a higher risk of falling and then lying immobile on a cold surface. Okay, they can't get to a phone. They're, if they're fell outside while they were getting the mail or whatever, right now they're outside on that cold surface for a while. So we also have nutrition and hydration. So a lack of food or water is going to aggravate hot or cold stress. So also use of alcohol or other mood altering drugs is often associated with cases of hypothermia. The vasodilation that's caused by alcohol provides a sense of that person feeling nice and warm, but also increases heat loss through radiation. And your environmental conditions. So conditions that can complement environmental situations. So air temperature, what the humidity level is outside. Is it windy? Yesterday up here in the UP, we had a really windy day. So people who were outside probably got cold bit quicker than what they would have had that wind not been there. So think about your homeless people as well, and people who, your elderly population. Some of them lack heat in their homes. Okay, and then also again going back to swimmers. These people are swimming in lakes and bodies of water that are not warm. So some hypothermic patients who have a risk factor for imminent cardiac arrest. So temperature less than 32 degrees Celsius in elderly patients or patients who have multiple comorbidities. So 32 degrees Celsius is 89.6 degrees Fahrenheit. And your temperature less than 30 degrees Celsius in young and healthy patients. And that equals out to about 86 degrees Fahrenheit. Here's a nice little slide. So some signs and symptoms, they're going to become more severe as the body's core temperature falls. And then hypothermia is going to generally progress through some specific stages. So let's take a better look here at those stages. So mild hypothermia, it's going to occur when the core temperature is greater than 93.2 Fahrenheit, but less than the normal 98 degrees. The patient is usually alert, but they're still shivering. Okay, they're alert and shivering. They are trying to create heat by doing that shivering, and they're also creating goosebumps. Okay, so as with larger muscles, contractions of the muscle and the skin will generate heat. So the raised hair follicles causes those skin pores to close, which kind of helps maintain that heat. Their pulse rate and respirations are usually going to be a little bit faster. You're going to start seeing some red, pale, maybe even cyanotic skin. Okay, that's your mild hypothermia. Your moderate hypothermia exists when the core temperature is 86 degrees Fahrenheit to 93.2 degrees Fahrenheit, okay? So this is when the shivering is going to stop. So you're going to start noticing that the muscle activity is going to start to decrease, okay? And you might start seeing some mental status changes as well. Their mental status is going to start to deteriorate. When we get into severe hypothermia, this is when your core temperature is less than 86 degrees Fahrenheit. So as the core drops towards 85 degrees Fahrenheit, the patient's going to become lethargic. They're going to stop fighting that cold, and the patient is going to start to appear stiff and or rigid. Now, if the body temperature continues to fall to 80 degrees Fahrenheit, you're going to notice that the pulse is slow and weak. Respirations are slow, and they may even be absent. You're going to start seeing some cardiac dysrhythmias that can occur. You're going to be looking for like atrial fibrillation, which is an irregular rhythm, or even ventricular fibrillation, right? So think of it as that bowl of jello that's sitting on the table, just kind of wiggling. So in the heart, and so that's what the heart is doing. It's really not making any rhyme or reason to what's going on there. So at a core temperature of less than 80 degrees Fahrenheit, all cardiorespiratory activity may cease. The pupillary action is going to be slow or completely stopped, and the patient may appear like they are dead or in a coma, okay? And now we never assume that a cold, pulseless patient is dead, right? We've probably all heard this before. They're not dead until they're warm and dead, okay? So what exactly does this mean, okay? You're not dead until you're warm and dead refers to people who entered cardiac arrest as a result of hypothermia. So when your body is too cold, everything starts to slow down and it isn't able to function properly, even if it wanted to. So they're going to enter into a fatal arrhythmia, which is that ventricular fibrillation. So now once they're at the hospital and have a normal body temperature, now it's okay to call time of death. So, but we're not calling it until they have reached a normal temperature. Okay. So what does that mean? That means that we start CPR. That means that we do all the things, right? And we transport to the hospital, and so where they can, start that warming process, okay? So there is something that's called ECMO, ECMO, extracorporeal life support. This has really changed the survivability curve in victims of accidental hypothermia, because determining patient viability in the field is next to impossible in the absence of like obvious mortality. Okay, so their head is cut off. They have a large gaping wound to their thorax area. Okay. It's really hard for us to tell that are they dead or are they, they could still potentially be viable patients. Okay. Current science supports the initiation of this treatment of the ECMO, and transport for patients in cardiac arrest due to that accidental hypothermia. So the manner of hypothermia, whether it be water, wind, air, snow, has no impact on survival rates. So it doesn't matter why they went into that hypothermic cardiac arrest. Okay. It's the survivability rates are going to be about the same. Okay. But we also have to talk about someone who is in cardiac arrest, and they are cold, but they were not in a situation where it is expected that the cause of death was hypothermia. So they're not found outside in the winter or found in a home that's freezing cold with no heat in the middle of winter. So these people then, if they're cold and dead, then they're dead. Okay. And I'm hoping that that's making sense. Okay. So, if you think about it, your average temperatures inside your home right now is probably about 78 degrees. So if, say, I died right now and laid on the floor here for hours, right, my temperature eventually is going to get cold. It's going to become the temperature that the environment that I'm in. All right. So I didn't die because of hypothermia. I died of other causes. So I'm hoping that makes sense. Okay. Okay, so there's a nice little study here where, or some survival stories here. So in 2013, a 65-year-old woman was brought back to life after having a core temperature of 20.8 degrees Celsius. All right, that is 69.4 degrees Fahrenheit. All right, and she was picked up by the ambulance. They did the CPR, resuscitation, brought her to the hospital, and where in the hospital she stayed for 13 and a half hours of rewarming, and they got a pulse back. All right. And also this big study from northern Norway, where they had 34 victims that they studied of accidental hypothermia with cardiac arrest. They were admitted to the Norway hospital between those years. ECMO was used on them, and 9 out of the 34 survived. Okay. So, and the lowest measured core temperature among those survivors was 13.7, which is 56.6 degrees Fahrenheit. Okay. So, again, they're not dead until they are warm and dead. So, let's talk about some lawsuits that have happened because us as EMS assumed that they were dead. Okay. So this one here that I have on the sheet. So we have parents of a college student. The college student froze to death in 2013. His name was Jake Anderson. He was 19 years old, found
Hang
along
on,
the
Lisa.
Mississippi River. Sure. Journey's having me hold on a second, so give me 1 second here. Okay. Sorry, guys. All right, so back to Jake Anderson. He was celebrating the end of his first year as a freshman. Responders who found him said that he was frozen to death. The suit referenced several cases where individuals had actually survived sub-zero temperatures for 12 hours. So even though that those patients did not have a pulse and that they appeared to be dead. So according to the attorney, Anderson was found in a hypothermic state, face down, slumped over a metal rail. He was most likely exposed to 0-degree temperatures from 2 a.m. until he was found 6 to 7 hours later. The lawsuit alleges that fire officials failed to recognize Anderson as a hypothermic victim and declared him dead after evaluating him for no more than 90 seconds. So they said no pulse, no breathing, he was frozen, and that was their reason for obvious death in their report. So, but about a week prior to this happening, Alyssa Lamel, another college student, was found frozen as well by a passerby. She had been exposed to minus 17 degrees for over 9 hours. She was taken to a hospital and she survived. Okay, so again, there are cases where we have got to start CPR on these patients, bring them into the hospital and warm them up. Okay. Looking back in my career, I can for sure say that there were 2 times where I could have potentially had a lawsuit because I did the same thing. We found a gentleman outside prone in the snow, and no pulse, no breathing. We put him onto the stretcher. He was asystole on our cardiac monitor, and we called medical control and declared him dead. Okay. And then I had another incident as well with an elderly female who wandered from her home. She had dementia, wandered from her home, found her hours later underneath a tree, and kind of the same situation. No pulse, no breathing, asystole on the cardiac monitor, contacted medical control, and pronounced her dead on scene. So, looking back on that, could we have potentially have gotten those patients back? I don't know. I don't know what the answer would be, but I didn't even give them the opportunity. And it was just a lack of knowledge to be, I just didn't have enough knowledge to say, no, we're going to continue to do the CPR and all the things and bring her in. So, okay.
Lisa, I have a
Do
question.
you have any questions up to this
I do.
point?
I'm wondering if you might not even know this. For the people that have survived the hypothermic cardiac arrest, do you know what kind of deficits, if any, these people had?
So, some of them have walked out with no deficits at all, and obviously there's going to be a range to that. And no, I don't have all of the data for that, and that's a really good question. I should have had that some more information for you. But some have walked out with zero deficits. Okay, so I mean, you got these younger personnel like this Alyssa. She was a college student. She's got age on her side. So, and she was one of them that actually walked out without deficit. Okay, so some general management of frostbite. So we're going to want to move the patient from the cold environment to prevent any further heat loss. We don't want to allow that patient to walk. Okay, so we're going to find wherever we find them, we're going to put them on our stretcher. We're going to move them that way. We want to remove all wet or restrictive clothing and then place them in dry, warm blankets. If we have warm, humidified oxygen on our ambulance, by all means, we want to use that. We want to handle them very gently. So we don't want to cause any more pain or further damage to their skin. And rough handling of a patient with moderate to severe hypothermia could potentially cause that heart to go into those into VFib or into cardiac arrest. Okay, so we want to make sure our heart does not like the cold. So if we start moving these patients around, it can kind of throw them into these rhythms. So we want to be very careful with that. We want to make sure that we do not massage the skin. If they have blisters that have formed on their hands or their face or their feet, we want to be careful that we don't break those blisters. We want to cover the frostbitten part with some soft padded sterile cotton dressing, and then we're going to transport them. Allow the hospital staff to perform the rewarming procedures if we have frostbite. Okay, allow that to happen there. Unless for whatever reason there's a delay in transport, we're going to be on scene for a while, and then we can go ahead and start that rewarming process. So your management of hypothermic cardiac arrest. So for the MFR and EMT level, I kind of broke this up into two different slides because of how we are kind of in the UP here. Anyway, we have a lot of basic squads, and then we have our intercepting squads that have our ALS personnel on there. So your MFR and EMT level. So now the protocol that I'm going to be stating is a Michigan state protocol. So if you are working in a different state, please follow that protocol. Know that protocol and follow that one. But this one, like I said, is for the Michigan state protocol. You want to assess their body temperature using a rectal temperature. Okay. Or excuse me, a rectal thermometer. We want to confirm cardiac arrest, okay, and begin CPR. Now, normally when we are assessing pulses for cardiac arrest, right, we go to the carotid pulse, and in all of the other literature, it says we don't assess for longer than 10 seconds. Well, in the case of hypothermia cardiac arrest, we actually have to feel for that carotid pulse a lot longer, from 30 seconds, potentially even up to 90 seconds. So you have to remember, when you were looking back at that one slide, how it said how the pulse slows down, okay? They could have a very, very slow pulse, okay? So this is the time when we're going to actually assess for that pulse a lot longer than those 10 seconds, okay? If you only do it for 10 seconds, you may miss something, all right? We're going to go ahead and start compressions at a rate of 100 to 120 beats per minute, so that stays the same. And you're going to put the AED on that person, and you're going to defibrillate if it's warranted. Okay, your AED tells you that there's a shock advised. You're going to go ahead and do that. Okay, now there is a caveat to this. Okay, we only in hypothermic cardiac arrest, we're only going to defibrillate one time. Okay, so even if that intercept comes, you have ACLS now that kind of hops on board with you, and they're still in that rhythm that can be defibrillated. You defibrillated once, okay, and we're not going to do that again. We are going to wait until we have rewarming of that body, and then potentially start at that time when they are now a normal body temperature. Okay. So defibrillate one time, and then CPR will continue throughout. Okay. You want to establish a patent airway. So that could be your supraglottic airway. Okay. If you have waveform capnography, perfect time to place that on. Okay. So does anybody know what the range for capnography should be? And if you don't, that's okay. So the range where waveform capnography, where we want to see that end tidal, it should be between 35 to 45. That is our normal range. Okay. We want to protect them against heat loss by turning the patient compartment temperature up. So you may be in the back of that ambulance doing CPR and sweating quite a bit, because we want that temperature to be up high enough to where we're starting to rewarm this patient. Okay. We're going to cover them with some warm blankets. Again, if you have that warmed, humidified oxygen, we want to use it. Okay. Start your transport to the hospital. Okay. We want to also apply some heat packs to their axilla, their groin, their neck, maybe behind their back, behind, in their knees, anywhere that you can think of. Okay. And start actually that warming process. Okay. And again, like I said, transport, right? So, and in our line of field, we're used to not transporting. We're used to doing the whole cardiac arrest on scene, and for 30 minutes, and if nothing changes, we call med control, we call the codes on scene most of the time, unless we get ROSC, and then we go ahead and transport. So these patients we're actually going to transport with CPR ongoing. Okay, so if you guys have a Lucas device or you have a CPR arm, obviously that's going to be the best thing to place on them, because while you're driving to the hospital, standing over them doing CPR, we know that the compressions aren't going to be as well as a Lucas device can deliver. The rate might change a little bit. So if we have a Lucas device, by all means, you're going to want to go ahead and place that on them and use that. Okay. At the advanced EMT level or the paramedic level, so now in the state of Michigan, the AEMTs are going to very soon going to be able to start being able to give frontline medication in cardiac arrest, which is kind of cool. So that's why I kind of put the two of you guys together. So first of all, you're going to do everything that the MFR and the EMT is going to do, but now we're going to add in some things. Okay, we're going to get that IV going, or the IO. Start with some normal saline at a KVO rate. If you suspect that this patient is hypovolemic as well, now we can go ahead and administer a liter bolus, repeat it if needed. But remember, these patients are probably in cardiac arrest because of hypothermia, not because of any other reason. Okay. You're going to go ahead and administer 1 milligram of epinephrine via IV and or IO. If they are in an antidysrhythmic, okay, so they're in ventricular fibrillation, they're in ventricular tachycardia, we're going to go ahead and administer 300 milligrams of amiodarone, or if you are a 100 milligram lidocaine person, one of those two medications is going to be given for this patient. Okay, so, and again, along with only one defibrillation. So if your EMT basic or your MFR has already defibrillated that person, we're not going to defibrillate anymore. Okay. And also now we're used to with epinephrine given every 3 to 5 minutes. Okay. We're not doing that in a hypothermic cardiac arrest case. We're going to give them the initial medication once and then initiate transport. And we're not going to administer any more medication until they are now warm. Okay. And depending upon what rhythm they are at that time. So let's talk a little bit about the services that we have in our area. So can anybody tell me if we have ECMO in Iron County or in Dickinson County? What do you guys think the answer is? No, we don't. Okay, so we're going to be transporting our patients to Dickinson County or to Iron County, right? We may have to now transport them as well up to Marquette or Green Bay to continue that process. So what happens is now we're doing CPR all the way to those areas as well. So they can be placed on ECMO, they can have that rewarming procedure done, and then potentially get a pulse back and, live out the rest of their days. Okay. So if we look back on some of the slides previous, like I had said, that one person, they were doing CPR on that person for 12 and a half hours. Oh, excuse me. They did ECMO on that person for 12 and a half hours before she was at a normal temperature and got ROSC or got that heart rate back. Okay. So, and like I said, and you guys can probably think in the back of, your head as well, some of us who have been in this field for a long time, there may be same situations where you have been, where you called a code on a hypothermic patient in the field. And if anybody would like to share that story, if you did, we would be happy to hear of it. And if not, that's okay.
Hey, Lisa, I don't know. I know you can't really see the questions, but Jeff had asked if there were any issues with performing an IO on a hypothermic patient.
There is not. So no issue with performing an IO. Go ahead and do to be honest with you, in a hypothermic patient, I would bet that it's going to be pretty difficult to get an IV started in this person. So my first line of access is probably going to be that IO, and I'm going to go into the tibial tuberosity in the lower leg. So I mean, if you think about it, this patient is very cold, they're very stiff, that skin is going to be hard to get through. You may not see any kind of vein access. So I would go and start the IO. So by all means, go that route. Were there any other questions, Jenny?
No, there wasn't.
No? Okay, awesome.
Lisa,
All right.
I had a patient who
Okay, guys. So that is the lecture.
Lisa,
I
Laverne was
apparently I
trying
talked
to
really
talk.
fast to everything. Who is?
Laverne was.
Oh, go ahead. For whatever reason, Journey, I can't hear. I'm gonna undo this real quick here. Okay, Laverne, go ahead.
you had just asked about, an incident that any of us might have experienced, and it came to mind that I had a lady who, she was about 90 years old, was found outside her house in her walkway, but there had been a melting and a refreezing, and half her body was in the ice. Her face was
Oh, wow.
above the ice. And so that is one that we did do the protocol of, checking her asystole, the whole thing, but we had to chop her out of the ice. But she went, we called it on scene, and she actually went, the funeral home actually came to the scene and transported.
Okay.
So I don't really feel that maybe that I shouldn't have called it because, with the freezing and rewarming, I don't know that that would leave a viable patient, I wouldn't think. I don't know. What do you think?
Right. Yeah. Like how warm did it get? I mean, obviously enough to where she like went into like a puddle, assuming, and then she just froze around that again?
Well,
Around her?
she was going out to her mailbox and she slipped and fell, and may have had head trauma. I don't know that,
Okay,
but
sure.
her body was incapable of resisting water ice that was frozen all under the desk down
Wow.
and then it was under like snow days, like it snowed down through the court. We don't know when she slept. Just the day reported your news. It was dark, but we I can't body.
Yeah. And you said that she was in her 90s, hey?
Oh yeah, yeah, and she probably was all of 90 pounds.
Okay.
She'd gone out like in a nightgown and like a sweatshirt, like definitely wasn't planning to be out long.
Okay. Right.
So the presumption was she was
Right.
going to the mailbox.
Right.
So, and
Yeah.
we were only,
Yeah, and
this was on the curve from the hospital going to the nursing home from Iron River. So it was right by the hospital.
okay. Okay. Yeah. Yeah.
So,
Yeah. I mean, and
but it's when I think about
at
now,
that
it's like, I
point,
wonder.
right. Would she have had deficits? I mean, at that age, she had a slip and a fall, so it's potential head trauma, and now she hypothermic cardiac arrest as well. Yeah. Um, I look back at those two that I had and wonder if I knew then what I know now. I know I would have started CPR on them and transported them, And then I also wonder, why then did medical control allow us to call that on scene? Why didn't they say, hey, dummy, we need to actually start CPR on these people and transport them, and I need you to follow this protocol? They never did that. So
But maybe based on the information
but makes
available
me
to them.
wonder, what. True. I mean, of course, this was 10, 15 years ago that this happened. So yes, we've had more studies since then, and we're seeing that more people are, actually getting ROSC from these events. So yeah, very true. They may not have had all that information either. So yeah, thank you for your story. Does anybody else want to share? No? Okay. All right, that's fine. So like I said, I obviously talked really quick through some of this, because those are all the slides that I have, and that is the lecture that I had wrote up for you guys. So if you don't have any questions, I am going to turn it over to this last slide here. Okay.
Lisa, I do have a question.
Yeah.
Like, I guess if you suspect somebody has frozen to death, or however you want to say it, like, do the modeling, lividity, rigor mortis, I mean, does any of that change? I mean, or take longer, or is not, I guess, as accurate as you would think if it were not a cold weather emergency?
Right. So when we look back, it's really difficult for us to tell um, if there's any of those obvious signs of death, right? So
Mm-hmm.
where in a normal person, normal temperature, you're going to see that lividity. You're going to
Yep.
you're going to all that kind of stuff, right? So with our temperatures, with our frozen temperatures, they're just going to be so hard and pale and cyanotic that's going to be really difficult to tell, is that lividity? Or is that hypothermia? Is that skin changes because they're so cold? And that's why we don't really want to, really pay that close attention to that per se. And I don't say, I guess I don't want to say don't pay attention to that, but don't let that be your determining factor as to why you're not going to start CPR.
Sure.
Okay.
Thank you.
You're welcome. Anita, I see that you have your hand raised.
Go ahead. Okay, Lisa, I have a question. Do you have to worry about this compartment syndrome with some of this stuff when you're rewarming? You don't want to rewarm too much?
Well, so with the rewarming process, what we're going to be doing in the back of the ambulance with our hot packs and the warm blankets and such, and you have to remember, it's not necessarily like one area that has that's going to have potential compartment syndrome, like an arm or, a leg. It's the whole body. Right. So and Laverne, if you want to hop in here as well, but I'm going to suspect that no, that is not going to be a concern of compartment syndrome. Okay.
Okay.
Laverne, did you have anything to add to that? Do you feel
No,
the
I
same
agree.
way
I
that I
agree
do?
because the fact is this is a systemic problem, not just a
Right.
limb problem. And
Correct.
if they're going to have any limb damage or that, it's going to be more from the freezing of the tissue in the fingers and the toes. And the rewarming process will try to heal that. They might end up with amputations of parts that aren't viable. But the
Right.
bulk is you want to rewarm the core, the heart and the brain.
Right. Thank you. All right. Anybody else want to add? No? Okay. All right. Well, I appreciate you guys coming to this class. And hopefully I'll see you guys next December 27th. So have a great night.
Every month, we offer free live CE courses for Michigan and NREMT EMS personnel. Participants will only be awarded CEs if they attend the live class. To learn more, send us a direct message, leave a comment, or join our Facebook group. We sincerely appreciate your interest and support. Thank you.